So I'm not going to read through this slide, but you need to understand the events of the cardiac cycle. Basically, you start at any relative point, but they start at the period of isovolumetric contraction as number one here. Then you've got the period of ejection, the period of isovolumetric relaxation, and then you have ventricular diastole, which is sometimes divided up into passive filling of the ventricles and active filling of the ventricles. Passive filling of the ventricles just means the atria are relaxed. Active filling means the atria contract. Now, when you look at the next slide, you'll realize that the ventricles are mostly filled passively. The atria really just contract and top off the ventricles. The other thing you may notice is when you watch the video, which you should watch the link to the other YouTube video that is on Canvas as well. They divide up the period of ejection into two different subphases. So just be aware you'll see the cycle broken up differently by different sources. So you need to understand what is going on this slide. Starting off by looking at your EKG trace at the top. Remember, your P wave is atrial depolarization, followed by atrial contraction. The QRS complex is ventricular depolarization. Also, at the same time, you have atrial repolarization, but you don't see that trace because it's hidden by the QRS complex. So you have ventricular contraction following the QRS complex / atrial relaxation. And the T wave is ventricular repolarization, and following that you should see ventricular relaxation. So what you're looking at here is different from what you see in page 278 on figure 22.1 in your lab manual. This has 2 cardiac cycles, and 278 in your lab manual only has 1 cardiac cycle shown. So again, it's usually started with a period of isovolumetric contraction. Some important things you want to know. During both the isovolumetric phases, remember all 4 valves are closed, and there is no movement of fluid. Isovolumetric tells you it's the same volume. What you have during those phases is a dramatic increase or dramatic decrease in pressure within the ventricles. And again, some things to know that are highlighted in that video as well. Fluid moves from where it's a higher pressure to a lower pressure. And remember, the valves only open and close. They allow blood to only flow in one direction. And whether blood will flow from one area to another and a valve set opens depends on the pressure difference between the two. So as you notice here, during the period of isovolumetric contraction, again, you look at the middle section. Remember, the red line is the aortic pressure, the blue line is the left atrial pressure, and the black line is left ventricle pressure. So during the period of isovolumetric contraction, the left ventricle is contracting and rapidly building pressure. The AV valves close at the beginning of that set because, again, they keep blood moving in one direction. But the semilunar valves only open once the pressure within the ventricle meets and exceeds the pressure within the aorta. If you did not generate enough pressure within the ventricle, that semilunar valve set would actually never open. So a brief period of time, you see the pressure within the ventricle and the aorta basically be the same during the period of ejection. And if you notice during that period of ejection as well, if you look at the third trace set down, you have the left ventricle volume. You have the volume of the ventricle rapidly decreasing during that period of ejection as the blood is leaving the ventricle and entering the aorta. So again, you have that kind of arch of pressure between the ventricle and the aorta. The pressure in the ventricle eventually drops to the point where it's below the pressure in the aorta. At the beginning of the period of isovolumetric relaxation, you have the semilunar valve set close, and then that's where you see that dicrotic notch. Again, a product of the fact that the aorta is elastic and it briefly stretches out and recoils back when those semilunar valves close. So that's why you see that brief jump in pressure at the in the aorta at the beginning and about during the period of isovolumetric relaxation. And again, what's going on in the ventricle, you see that rapid decrease in pressure until it reaches below the pressure of the atria, which is the blue dashed line. It doesn't have to be very far below, but if you notice during that period of ventricular filling, the pressure within the ventricle is below the pressure of the atria. So the blood is going to flow from the atrium into the ventricle during that relaxation phase between your T wave and the P wave of the next cardiac cycle. And again, you look at the volume of the ventricle. The volume is probably the ventricle is probably 3/4 full before the P wave even occurs, and you have atrial contraction. So you see the passive ventricular filling versus the active ventricular filling. The active, again, when the atria actually contract. So the atria really only top off the ventricles when they contract. And then you start yourself a new cardiac cycle. And again, remember the heart sounds. The S1, or the first heart sound, is produced from when the atrioventricular valves close during that period of isovolumetric contraction. And the S2 sound you hear when the semilunar valves close at the beginning of the period of isovolumetric relaxation. So again, trends to remember: all four valves are closed during the isovolumetric relaxation contraction phases, but the valve sets open or closed at the very end or the very beginning of those two isovolumetric phases. So you should kind of be familiar with those as well. And again, as I said in class, ignore that third heart sound. We're not going to talk about it, and it's not always present anyways. Again, this was just for information for the nurses. I'm not going to test you on this, but you can just selectively hear what's going on within the four valves, the two pulmonary, the two semilunar valves, and the two AV valves, depending on where you put your stethoscope on the chest of the patient. Now you should know all the pulse points here. I believe those pretty much correlate with what you see on Activity 2, page 280 in your lab manual, but you should know the pulse points by name and a description of where they are located. So again, this slide is not something I'll particularly question you on, but it does explain why you hear carotid cough sounds. Remember, the top picture is laminar flow in a vessel that is unoccluded, and you don't really hear any sounds in laminar flow. But on the bottom is what's referred to as turbulent flow, and that is caused by a constriction in a blood vessel, and you get those little turbulent eddies that are basically vibrations, and you hear as noise. So that is the source of the carotid cough sounds when you are taking blood from a blood pressure cuff or sphygmomanometer. So this correlates with what you see on page 281, activity 4 in your lab manual. You should understand how to take a blood pressure with a sphygmomanometer and a stethoscope, and understand what is going on within that artery distal to the blood pressure cuff. So you again wrap the cuff around the arm. You place the stethoscope over the pulse point, or over the radial artery within the bend of the elbow, the antecubital fossa, and pump the pressure up in the cuff above what you expect the systolic pressure to be. So at that point, the artery is totally occluded during both systole and diastole. You slowly release the air within the pump and watch as the pressure decreases within the cuff. When the cuff reaches the same pressure as the systolic pressure, you will hear your first heart sound. And that will be an artery, as you see on that diagram on the right there. An artery under systole is just very slightly open, and you'll hear your first heart sound, and that is what you will report as your systolic pressure. And as you decrease the pressure gradually, eventually the vessel will be totally open during systole, and you'll hear the heart sound during diastole, as there is still some occlusion. When you hear the last heart sound, that is a cuff pressure that is equal to your diastolic pressure, and what that's saying is your artery is now totally open during diastole as well. So again, you remember you only hear heart sounds during a partially occluded, when a vessel is partially occluded. You will not hear heart sounds when the vessel is blocked, as you see above the blue arrow area there, and you will not hear heart sounds when the vessel is totally open, as you see below the blue area. And again, this slide is not something I would particularly question you on, but I do feel it's important to kind of understand. So you have a variation in your pressure, the systolic and the diastolic pressure, right at the aorta. And as you get farther and farther from the heart, two things occur. Both the amount of variation between systolic and diastolic decreases as you get farther away from the heart, as well as the pressure in general decreases as you get farther and farther away from the heart. And it is an important concept to remember that the pressure in capillaries is still higher than the pressure within veins and the vena cava. Remember, blood travels from a higher to a lower pressure, so the lowest pressure in the body should be in the right atria. Eventually, blood will flow into there from the vena cava. Again, it's a common misconception that people think blood pressure is lower in the capillaries than it is within the veins, because the capillaries are smaller vessels, but that's simply not the case. So always remember, blood flows from an area of higher pressure to lower pressure.